I have a very basic question. See, you're actually comparing an elegant technique of phacoemulsification with SACS trap. And what is the incision size in SACS?
So we used to back the shape incision.
5 mm, 5 mm, 5.5. What is the phaco incision?
Phaco was 3.2, sir.
So how can you really compare two different technologies? One is clay conning, one is squirrel tunneling. The second is you have done SACS trap in the same site.
Yes, sir.
So how do you again compare two different techniques of surgery with two different incision sizes, and then you're comparing onions and apples? So I really don't know what exactly you're trying to say, but what is your conclusion? Is that SACS trap is not good?
SACS trap had both. The reason why we did the study was because it was big.
Because some of our patients in the community setting, we do SACS trap all the time, and we get fantastic results with SACS trap. From your paper, I come to conclude that maybe SACS trap is not a good idea, and phaco trap is the way to go. Is that what you're trying to say?
Early visual stabilization would be definitely more in the phaco trap group.
Okay.
Do you suggest that we should do SICS in two different sites? It should not be one single site. Do you suggest that? You are doing a lot of SICS.
Yes, I think we can definitely do two-site SACS trap. You can do a temporal SACS and you can do a traps anteriorly or nasally, wherever you like. If you really want to do a study comparing phaco trap and the way you've done, you should probably do two separate sites and then compare and then present your results. Thank you, everyone.
My paper is on the comparison of the ability of swept source and spectral domain OCT to evaluate the anterior chamber angle. None of the authors have any financial interest. As we all know, primary angle closure glaucoma is a major form of glaucoma in Asia, and evaluation of the anterior chamber angle is the first step in the diagnosis of angle closure. Although gonioscopy is the current standard, it is a relatively invasive procedure, and the results rely on the examiner's subjective assessment and experience. Now, OCT has become an important tool in the objective assessment of angle structures. It has evolved from time domain to spectral domain and now swept source OCT. Our aim was to compare the ability of the swept source and the spectral domain OCT to image the anterior chamber angle structures, and this in turn was compared with gonioscopy. Patients were recruited from the glaucoma clinics, and one eye of each patient was randomly included in the analysis. Patients who had undergone intraocular surgery and known to have uveitis were excluded from the study. The patients underwent detailed ophthalmological examination followed by gonioscopy. Gonioscopy was done by a single ophthalmologist who was in standard dark and light conditions, and an angle was classified as closed if the iris was in contact with the trabecular meshwork or structures anterior to it. This was followed by anterior segment imaging. Both SSOCT and SDOCT images were taken by a single trained technician, and the images were then analyzed by an ophthalmologist who was masked to both clinical as well as the gonioscopic findings. Once the images were taken, the angle structures were marked. The Schwarz line was the point of termination of the decimus membrane, and scleral spur as defined as the point of change in the curvature of the inner surface of the angle wall. Trabecular meshwork was identified as a low signal area between the Schwarz line and the scleral spur. Then the quadrants were classified as open and closed. A closed quadrant was identified based on the contact of the iris with the anterior structure angle wall anterior to the scleral spur in SSOCT images. This image where the examiner's thumb has obscured the angle view, and this one where the pterygial mass has eclipsed the angle view were excluded. All such images were excluded. This one being a shaken image was also excluded. Similarly, in the SDOCT images, the angle structures were marked. They were then classified as open and closed. The definition of closed quadrant remained the same as for SSOCT images. In quadrants where the scleral spur was not visible, the trabecular meshwork was used as a surrogate landmark in the definition of closed angle. 47 patients had recruited, and average age of the participants was 54.7 years. Majority of them were females. The scleral spur was visible in 76.9% of the SSOCT images, but much less often in the SDOCT images, whereas the Schwarz line was seen in 62.9% of the SDOCT images, yet only in 17.9% of the SSOCT images. Trabecular meshwork was almost equally imaged with both the imaging modalities. The poorer visibility of the scleral spur with SDOCT compared to SSOCT was significant in all the quadrants, the significance more being in the horizontal meridians compared to the vertical meridians. On analysis, we found both the devices detected closed angles equivocally compared to gonioscopy. The AC1 statistics showed both the imaging techniques to have good agreement with gonioscopy. Few similar studies have shown that ASOCT to detect more closed angles than gonioscopy could have been due to the fact that infrared rays are used in the ASOCT, whereas with gonioscopy the light rays are used, which have the tendency to open up the angles, and with gonioscopy there is invariably inadvertent indentation which will open up the angles. With gonioscopy, the posterior trabecular meshwork is used as a landmark for closed angles, whereas with OCT, the scleral spur is used as a landmark which is posterior to the trabecular meshwork. Pereira et al. Showed STOCT to detect closed angles less likely, and this could have been due to the fact that STOCT uses the 840 nanometer wavelength, which detects Schwalb's line better than the scleral spur. Our study had few limitations. The sample size was small. The observer performing gonioscopy was a single person, who should have led to systematic bias, and external fixation was not standardized. To conclude, SSOCT appears to be more robust in detecting the scleral spur and STOCT in detecting the Schwalb's line, which could be attributed to the difference in the wavelength of rays used by the two machines. Both SSOCT and STOCT appear to have good agreement with gonioscopy. Having said this, for these instruments to replace gonioscopy, it's going to take many more years. By when we hope these instruments become cost effective and give a 360-degree view of the angle. Thank you.
Which machine is SSOCT?
Cassia, sir.
Tommy.
Yeah.
Thank you.
A case study which we did in Arvind Madurai, comparing the safety and trabeculectomy of mitomycin with trabeculectomy with Ologen implants. It's a randomized clinical trial. There's no financial interest to disclose. As we all know, glaucoma patients will increase in this years to come as the aging population is increasing and the advances in the diagnostic futures. And this will have an immeasurable effect on the social and economy of the world. Though many surgeries have been introduced as surgical options for glaucoma, trabeculectomy still remains the gold standard method. However, blood failure due to episteral fibrosis and subconjunctival scarring is the major concern. So the adjuvants were introduced for trabeculectomy with mitomycin and 5-fluorouracil. However, as we all know, mitomycin is associated with numerous complications like blood leak, phlebitis, and endophthalmitis, hypertonia, like that. Recently, Ologen, a tissue bioengineered implant, has been introduced as an adjuvant for mitomycin. It is used as a subconjunctival implant which modulates the wound healing process and works as a spacer and prevents the collapse of the subconjunctival space. It optimizes the wound healing, reduces the postoperative scar formation. So the aim of the study is to find which agent is more appropriate, either it's mitomycin or Ologen. And there is no similar randomized trial study in India before. So the primary outcome is the intraocular pressure, and secondary outcomes are the number of anti-glaucoma medications needed, visual acuity, and complications. It was a randomized trial with 50 eyes, 25 in each group. And the inclusion criteria, it was all primary glaucomas, adult onset primary glaucomas. And exclusion criteria were the secondary glaucomas, one-eyed patients, and previous history of any glaucoma surgeries. This surgery was approved by the Institutional Review Board, and we got informed and written consent from all the participants of the study. All the patients were underwent a thorough glaucoma evaluation. Coming to the surgical part, all surgery was done by a single surgeon under standard surgical protocol. In the mitomycin group, 0.2 mg per ml of mitomycin was used for 3 minutes. And every patient's scleral flap was closed with one fixer and 2 releasable sutures. And a cylindrical Ologen implant was placed on the scleral surface in the Ologen group. The follow-up was done for 6 months on the day 1, then 1 month, 3 months, and 6 months. In each visit, the following parameters were assessed. Coming to the results of the study, all results were analyzed with the Stata 11 software. Pre-op characteristics were almost similar in both the groups, and one patient was lost for follow-up in each of the group. Comparing the intraocular pressure, there was significant drop in the intraocular pressure in both the groups. And there was no significant difference in the IOP variation in both the groups, except at the 1 month follow-up, where Ologen showed a little lower IOP compared to the mitomycin. Compared to the anti-glaucoma medications, both the groups did not significantly differ in the needed for anti-glaucoma medications post-operatively. Surgical failure was equal in both the groups, but the complete success was better in the mitomycin C group. There were 6 complications in the mitomycin group and 4 complications in the Ologen group. and failing bleb was the most common complication in the mitomycin group. But it recovered well after bleb needling with 5-fluorouracil. Visual outcome was almost similar in both the groups. Comparing the bleb characteristics, type 1 bleb was more in the initial first post-op day in the Ologen group, might be due to physical presence of the implant, but at 6 months there was no much of a difference in both the groups. So conclusion, there is no significant difference in the post-operative behavior of these two groups in the 6 months follow-up. So Ologen doesn't offer any significant advantage compared to the trabeculectomy with mitomycin. Further randomized clinical trial with long follow-ups are needed to compare the real safety and efficacy of these new implants. Thank you.
What's the price of Ologen?
6,000 rupees.
And so if it's not going to have that much benefit, then there's no point of buying it, is there? Same surgeon?
The same surgeon, yeah.
Who?
Dr. Sharmila.
Okay, thank you.
Well, it works, but in the short-term period, results are not that encouraging. So maybe that's what the speaker wanted to point out. Thank you.
Any questions from the audience? Anybody would like to ask or comment on any of the papers presented last hour or so? Nobody has any questions? Yes. You had pointed out that
Large number sample size, that would have made it more interesting. Thank you. Thank you.
It's a non-contact, non-invasive technique which has revolutionized ocular disease management. Well, we all know that the retina has a layered anatomy. We know this from old drawings, from recent histological sections, and now the OCT gives us the details of the retina in exquisite detail. The OCT made its debut in 1995 with the OCT-1. You see the image was not of a very high resolution. Over time, it has evolved from the Stratus OCT-3 to spectral domain OCTs, and now there have been newer innovations in the software which give us even very, very clear images. There are many different spectral domain OCTs machine available in the market. The more popular ones are the Cyrus from the Zeiss, Heidelberg Spectralis, the Topcon, the RTView, and there are so many more. So there are many spectral domain OCT machines now. However, most of them have similar scan protocol principles. That is, the principle of scanning and the way you read the printout remains the same, though the printout may be different for all the machines. Well, of course, in the olden times, it used to be easy for us to read the normal scan because we just had one machine and we just had to read this printout. However, like I said, with the newer machines coming in, every machine has a different printout and we need to be familiar with whatever machine we are using. I'll be dealing mostly with the Zeiss Cyrus OCT. So the OCT scan protocols for these are a volume cube. These are the two most commonly used protocols, and a high resolution raster scans. This is the printout of the Cyrus OCT. Here you see here's the signal strength. The signal strength here you see is 10 on 10. Ideally, the signal strength should be more than 6. In case it is less, your image quality will not be very good. So do check for media opacities, a well-dilated pupil, that the patient's cornea is not dry in case your signal strength is low. Here you see the fundus image and overlay. This is the overlay on it. This is a retinal thickness map. Here you see that the white color indicates that the thickest part of the retina, and the black indicates thinner part of the retina. So here this white indicates the retina is thickened over here. These are the color codes for the different thicknesses. This is the macular map which tells you the retinal thickness in different quadrants. This is divided into 3 zones. The inner zone, which is 1 millimeter, this is 3 millimeter, and this is 6 millimeters. So these are the thicknesses in various quadrants of the retina, and this is the central thickness that we most commonly use. This is the fundus image. This is the 3-dimensional surface scan of the retina. This shows a 3-dimensional view right from the internal limiting membrane to the RPE. This shows just the internal limiting membrane, a 3-dimensional structure. You see this elevation. This shows the RPE. These are the fundus. These are the OCT scans. This one going from temporal to nasal, and this one going from inferior to superior. This, as I mentioned, is the central subfield thickness, which you see here, the thickness of the retina in the central zone, which is most commonly taken measurement. The cube volume gives the volume of the entire cube from the ILM to the RP in the 6 by 6 millimeter cube. So this is how you read this printout. So some practical tips while seeing the printout. While you're doing the OCT, look at all the images. So otherwise you'll miss significant data. Don't just see the printout. Go live and see it on the OCT machine if you can. For the Stratus machine, review all the 6 scans and the map. Don't just see one scan which is there in your printout. Similarly for the spectral OCTs, if you can, see all the scans. Another point I'd like to make that retinal thickness may be different on different OCT machines. Like you see on the Stratus, the thickness of the retina measured in various studies is 206 microns. The Cirrus gives a higher thickness and Spectralis still higher because they measure the thickness from the ILM to different layers of the retina. Therefore, if you're carrying out a study or if you have follow-ups of patients, do make sure it is done on the same machine. Otherwise, you will have a variability in the readings. So coming now to how to see the retinal layers. The retinal layers are given a color code depending on how the light reflects from the various layers. These are all false color codes. Highly reflective structures are red in color, moderately reflective are green, and less reflective structures are blue. So here you see this is the internal limiting membrane and the nerve fiber layer, which is red in color. These are the various other layers, the ganglion cell layer, this starts with the ganglion cell layer, inner plexiform, inner nuclear, outer nuclear. This is the outer nuclear layer, this blue zone. All these layers are not very clearly identifiable. There are different various strips over here, but this outer nuclear layer is very, very clearly seen here. Below this is this line going, which is called the external limiting membrane. This is a very important landmark in the spectral domain OCT, and because just below that is the IS-OS junction. That is the inner segment, outer segment junction, also called the photoreceptor integrity line. And this is a term that you're going to be hearing a lot now with the future newer generations OCTs coming up. And this is the line that we watch out for. If this line is intact, the patient will have a good vision. Below this line is the retinal pigment epithelium. Below that is the choroid. This is all the choroid. So these color codings may sometimes give a misrepresentation of the retina. Therefore, in the spectral OCTs, we see black and white images. So here you see the black and white images are more clearer. So that all the layers, again, the nerve fiber layer, ganglion cell layer, inner plexiform, outer nuclear. This is the outer nuclear layer, external limiting, IS-OS junction, RPE, and here is the choroid. Again, this is just to show the layers compared histologically. Whenever you see an image, how do you go about interpreting it? The first thing is to identify the two major interfaces, that is the retina vitreous interface and the retina RPE interface. Whether you're working on the time domain or the spectral domain, identify these two layers first. After that, start looking sequentially at all the structures. Look at the posterior vitreous phase, vitreoretinal interface, neurosensory retinal layer, IS-OS junction, retinal pigment epithelium, and the choroid, which is now visible with recent enhanced depth imaging in various machines. Another point that I'd like to tell you is that the nerve fiber layer is thicker near the optic disc. So if you see a scan like this where the nerve fiber layer is visible on one side and not on the other, this means it's a horizontal scan. This is the nasal side. Another thing that you have to keep in mind is superficial structures often affect the underlying tissue, and just like an ultrasound, they also cast their shadow. So if there's a highly reflective structure in the vitreous, the layers below it are not going to be seen because of the shadowing effect. In spectral domain OCT, you can also see the shadowing of the vessels. These are shadowing of the vessels. This is scan taken near the disc. Again, to illustrate shadowing, this is shadowing from blood. This is shadowing from this retinal pigment epithelium. There's pigment collection over here. So you see these layers are not seen. This is reverse shadowing because here you see there's RPE atrophy. So these layers are seen even more clearly because there is atrophy of the retinal pigment epithelium here. So this is called reverse shadowing. Like I said, you see the vitreoretinal interface. The next speakers will be discussing these entities in detail. I'll just give you a few quick pictures. This you see the vitreomacular traction. You see the nerve fiber layer is a little jagged, and you see the vitreous hyaloid face attached to the nerve fiber layer. All the other layers are more or less intact. This is an epiretinal membrane which is covering the upper surface of the retina, and here you see this upper nerve fiber layer all jagged. The photoreceptor integrity line is more or less intact, so this patient will have a good vision. This patient had a vision of 20/25. Here you see intraretinal cysts in the, this is in the nuclear layer. A branch retinal vein occlusion, intraretinal fluid you can see, but down below you see the layers are not seen because they are shadowed, they are obscured by the blood over here. The retina is thickened here. This is a very typical picture of a BRVO where you see an asymmetric thickening. One part is thickened where the BRVO is present, the other part of the retina is flat. I forgot to mention before that this foveal contour is something that you have to see in all OCT scans. If the foveal contour is maintained, the patient will have reasonably good vision. If in case the foveal contour is distorted, the patient will have a decrease in vision. This is the picture of a CSR. Here you see a neurosensory detachment. This is the retina. This is the RPE. As you go further, you see the RPE itself is elevated here. So this is a pigment epithelial detachment. This layer you see here is the Bruch's membrane, which is seen below the RPE. A very mild, mildly reflective layer. You see the PIL, that is the photoreceptor integrity line, is well maintained. So I've been talking about this. This is the junction, this photoreceptor integrity line or ISOS junction is the junction between the outer and the inner segment of the photoreceptors, and this correlates very well with visual acuity. So, for instance, in this patient you see vision of 660. This was a patient who had trauma, and you see that the photoreceptor integrity line is only till here and it doesn't carry on after that.
On the other side of the day you may think it's gone. That is not right.
The fovea may be normal, but there may be edema which is localized to the side, or there may be even a CNV which is localized to one side, and you could miss it because, as Tinku told you, it's like an ultrasound. In an ultrasound, if you don't cut the section properly, you got nothing. The same thing applies to an OCT, and this is a mistake which often happens because you say, okay, ये picture आ गई, machine ने picture दे दी, उसमें picture में क्या आया, उसने जहाँ से काटनी थी काट दी, but it is not cut from everywhere. Now you have to physically move your cursor till you go through. This depends on the machine you are using. But since the representative here was a Cirrus, in a Cirrus machine you have to now take the cursor through horizontally and then vertically and see what was the pathology in each of those areas. The area which is red, why is it red? Is it edema? Is there a CNV? Is there traction? Those things will only come when you look at each of those specific areas. So, which I think will come later on in the other talks. We can discuss that.
Good afternoon, everybody. I will be speaking on OCT features in vitreoretinal interface disorders, findings and response to treatment. So, vitreomacular interface disorders is a new emerging entity, and it is implicated in the formation of ERM, macular hole, lamellar macular hole, vitreomacular traction, pseudo hole, DME, AMD also. It can have its effect, myopic foveosis. The list is not complete, but I have taken the most commonly known entities. Vitreous and PVD. The vitreous is the largest structures within the human eye, but till now we did not have any diagnostic modality to look at it. We just used to rely on the slit lamp examination. But now with the OCT, the picture is changing. So it is usually solid in infancy and youth, and as one ages, the vitreous liquefies and then it separates from the retina. So this is known as normal PVD. Anomalous PVD is very important because all these entities happen because of the anomalous PVD. In anomalous PVD, the liquefaction happens faster and the separation does not keep pace with it. So the vitreous becomes liquefied and suddenly starts moving, and then it causes traction on the macula. So this is anomalous PVD. If the traction is axial, you get VMT, vitreomacular traction. And if it is centrifugal, that is, the vitreous is still attached to the disc and it is being pulled away from the macula. that is known as centrifugal traction, you get a macular hole. And the other way around is, if the vitreous is not attached to the disc, but it's attached at the fovea or posterior pole here, and the traction of the forces are inward, you get a epiretinal membrane. So there's a new classification that has now come, that is the International Vitreomacular Traction Study Classification System, where the vitreomacular adhesion is, you can classify into focal or broad depending on the area of attachment. Then there is vitreomacular traction, it could be same way as focal or broad, and the full thickness macular hole. It can be divided into small, medium, and the status of the vitreous, whether with or without VMT. And then it could be the cause, whether it is primary or secondary. So this is the new classification that we should be using. So this is vitreomacular adhesion. Here you can see that the vitreous is attached in the center. So elevation of the cortical vitreous above the retinal surface. So the foveal contour is still maintained, and the vitreous is attached within 3 millimeters of the radius of the fovea. And there's no changes on the OCT, the patient is asymptomatic. And most of this will resolve. So this is known as vitreomacular adhesion. And we say it as traction when there is detectable changes on the OCT and the patient is symptomatic. Here you can see the vitreous is pulling the retina, and you can see some cystoid spaces when the patient is symptomatic. This is a VMT example. The patient, 60-year-old male, 618 vision, complained of distortion, underwent vitrectomy with vitreous release. And this is the post-operative. You can see the foveal contour is normal, and the patient had improvement in vision. Epiretinal membrane, it can be idiopathic or secondary, and it is seen more in elderly patients. Secondary ARM you can get after retinal breaks, detachment, post-surgeries, post-cryo, trauma, and the idiopathic usually does not have a underlying cause. So here you can see the ARM. This is a secondary, it has multiple attachments, and most of the times vitrectomy gives good result. Almost 80% of the patients will have improvement in vision, but the value of the surgery has to be determined. The patient has to sort of gain the surgery, because you just can't operate for 6, 6, 6, 9. If the patient is happy with the vision, then you can wait and watch. But if the patient has distortion, complaints of decreased vision, it's a good surgery to do. And staining, and most of the time we aim for the ILM peeling, because once you peel ILM, you are sure that whole of the vitreous has come out. And you can stain the ILM, it makes the surgery easier. And most commonly we use the brilliant blue, and it reduces the recurrences of the ERM. But it needs some skill, because the ILM is transparent. So you should not be hell-bent on peeling the ILM. So if the patient has 6/9 vision, and if it's a ERM, it is possible that you can get away with just doing ERM removal. But if you have the skills and the technique, then most of the cases aim for an ILM removal. This is a case 1. You can see a secondary ERM post-CRVO patient. He was not responding to anti-VEGF because the traction is significant, and then the patient underwent vitrectomy plus ERM removal plus ILM peeling with good response. This is a case of Coats disease. So the patient had multiple sessions of cryo and laser. This is at the presentation. Over a period of 1 year, the patient developed secondary ERM, and then is a child. So then I took for vitrectomy, and the patient did well with improvement of vision to 6/9. This is another case, 365-year-old male physician with 6/9 vision with distortion, and this is the ERM. You can see it's quite significant. The CFT is more, foveal contour is lost, and this is the corresponding angiogram. You can see the leak that you can see on angiogram. And the patient underwent vitrectomy, and this we have the bioptician, that is a handheld SDOCT. This is intraoperatively. Immediately after the ERM removal, we did the SDOCT, and you can see that there's no ERM. And this is at 3 weeks post-op with good improvement, and the foveal contour is almost normal. So recurrences can be there in ERM removal, and you have to be careful. Too much of light, throwing a light on the macula also can cause phototoxicity. This is a small video. So this is it's very significant ERM. I used brilliant blue, so it has stained the ERM also a little, but usually it stains the ILM very well. Here you can see the ILM is being peeled. So the staining can be done under air or under saline also, whichever way you are comfortable. So this is just to show you that how the ERM peeling is performed. And macular hole, stage 0, no abnormality of foveal contour, oblique insertion of the hyaloid. Stage 1A, that is foveal splitting on OCT, lost foveal contour, and the inner layers are involved. And there is another entity that we now call is an impending macular hole. That is stage 1A and stage 1B. In stage 1B, you get a pseudocyst, and this enlarges, and the entire thickness of the retina is involved. Outer retina also is involved. So all this stage 1A, stage 1B is now known as impending macular hole. And stage 2, film thickness defect less than 400 microns. Stage 3, full thickness defect more than 400 microns. And still there is persistent attachment of the hyaloid. And stage 4, there is a full thickness defect with PVD induction. So the PVD is not attached to the retina. And this is a macular hole case. Patient 618 vision, underwent vitrectomy with good improvement, 6/9 at 3 months. So most of these cases need ILM peeling with prone position for 1 week. And the lamellar hole, there's the irregular foveal contour, defect in the inner fovea. You can see there's a defect in the inner fovea. Intraretinal splitting is there, and the intact photoreceptor layer. This is the ISOS, so it is intact. And most commonly it is associated with ERM. It's a very slowly progressive condition, so you have to be careful in selection of the cases. And there's another entity that is known as pseudo hole. That is a steepened foveal pit. Here you can see the pit is steepened, but you don't get this sort of lateral extension of the, there's no loss of the retinal layers here. And benefits by ERM removal. Another entity is myopic foveoschisis. So this is very commonly being seen now because of the free availability of SDOCT. The term was coined by Takano and Kishi, and diagnosis is more seen in elderly people. And the pathophysiology is the tangential traction. That could be due to the ERM. The ILM is rigid and tense, and the traction of the retinal vessels itself can cause traction at the fovea, which can lead to foveoschisis. And then there is the axial traction also, and there is a weak adhesion between the neurosensory retina and the RP due to the severe myopic chorioretinopathy, disparity in the length of sclera and retina. So all these very potent inward traction forces causes myopic foveoschisis. So these are the 3 types: retinoschisis type, foveal detachment type, and the macular hole type. These are the 3 types of myopic foveoschisis that are commonly seen. And this is a patient with myopic foveoschisis. You can see this is the thickened, it could be ERM also or ILM also. This is known as premacular structure, and you see a foveal detachment. So at this stage it can progress very rapidly to macular hole also. And this patient underwent vitrectomy plus ILM peeling plus FGE, and this is at around 17 months. You can see with good resolution, and the patient had improvement in vision. And the vitreomacular interface and DME, there also plays a part. 20% of the maculopathy group had PVD versus 50% of no edema group. So patients with macular edema are most commonly don't have PVD. And separation of the posterior hyaloid can relieve the traction. So here you can see there is a PVD was there. So spontaneous PVD reduce the edema. And the vitreomacular traction this time also will need surgery. Thanks.
Anything else you want to say? I mean, few words you want to say in the conclusion?
Yeah. So basically, one slide I wanted to talk about the pharmacologic vitreolysis also. So now we have a chemical.
No, but we are talking about OCT. We are not talking about the management of this thing. So the only thing is they gave a very valid point, which I liked was even if a patient is having an ILM, he is having a vision of 6/9 or 6/6. He is having no metamorphopsia. So many times these patients are advised surgery. They are not to be operated, only followed. You can give them amsulograde, you can call them for repeated follow-ups and all, and that's that. Next speaker in the meantime will come there, and Dr. Would you like to add something?
I think as the point is made, basically you are now able to see a lot more. But everything that you see as a pathology doesn't need treatment. So that is where your holding the hand is sometimes as important as knowing when to go.
Dr. Benikar, he is a man who, I call him an ROP man. He's done tremendous work on ROP. And I appreciate really, he's been following his work since he was in Chandigarh.
Thank you, sir. At the outset, I'd like to thank Dr. Tiwari and Dr. Talwar for this opportunity. Since it was unusual cases and dilemmas, and since my co-speakers were going to take care of most of the other conditions in the front and back part of the eye, I thought I'd deal with some lesser dealt with problems. Pediatric retina, I'm going to just deal with 6 common cases. As Dr. Tinku mentioned, now even the general ophthalmologist is often faced with OCT reports, and you may come across some of these, and about 4 cases in the uvea. Now, pediatric retinal OCT has come of age. I think this has been in the time domain era. This we call the flying baby position. But today, with the availability of the bioptogen or even the spectralis, which you can dismantle to make a handheld, pretty much pediatric, right, you can image a baby as old as even a few days old, as long as you mummify it. So the first thing we want to know, and as Dr. Bali has already shown you the normal foveal layers of an adult, and that's this. So these are the inner retinal layers, and the red ones will be the outer retinal layers. And the foveal center, the ILM fusing to that hyperreflective point, the foveal tent, and so on. Now see how this looks different in a baby. The first thing you notice is the foveal tent here is really not very tall, so it's shallow. The outer plexiform layer has not touched the inner limiting membrane, and that's called the immaturity of the inner retina. So not all of us are born, in fact none of us are born with the normal adult OCT, and that's important to know when you're looking at it. In fact, as you grow older, even inside your mother's wombs, your fovealization is happening. So depending on what week this OCT is taken, you may or may not even see a foveal dip, so that's important. So now let's look at some cases that are commonly seen and common in clinical practice, even to the general ophthalmologist. All of you know that this is ocular albinism. This is a 3-year-old baby. And you may or may have guessed already that this is foveal hypoplasia. Now, not all ocular albinotics come with foveal hypoplasia, but this one certainly does. It's very important to prognosticate to the parents, because these children typically present with nystagmus. So you see the absence of the foveal dip, and of course the immaturity of the inner retina, although the photoreceptors look fairly normal except for the absence of the foveal tent. This is just to show you a case and example of how young you can diagnose even a tumor, although it may be benign. This is a serendipitously picked up tumor, the combined hematoma, in a baby who was otherwise undergoing ROP screening. So you can pick that up, and you may doubt even your clinical acumen to pick that, but then of course you do the OCT and you see how well rounded that tumor is. Now all of us know that the combined hematoma has to involve layers of the RPE, even by definition. But here we showed that this is possibly such an early pickup of the disease that even the EDI, and she mentioned that the enhanced depth imaging can actually help you pick up the more outer layers. So here you see the RP is fairly spared, and this could possibly be the very early pickup of a condition. Now this is much like many other conditions we know in ophthalmology, where the patient sees nothing and you see nothing as well. It looks like an almost normal retina, but if you look carefully, this macular sheen, the sheen of the macula is not normal. The foveal reflex is a little bit displaced, but the peri and the parafoveal reflexes really hit you in the face. And this is now time to, and of course they have other features like eye poking, nystagmus, maybe even consanguinity. But the important thing here is the OCT helps you. You can see already that the neurosensory retina is so thinned out. This is not the way she mentioned. Normal layers will be between 200 and 250. Even children go from 180 to 220. And what you're seeing here is what we call a reverse ratio. The choroid is as thick, almost, or sometimes even bigger. And of course, this is just the way because of the thinning of the neurosensory retina, is much more the way the light reflects. It's not that the choroid is actually thicker or thinner, it's just the way that it's captured. So this inverse ratio is very important. Of course, you see the inner retina is so immature. There's no foveal dip, and there's almost no ISOS junction. You see this layer here is the retinal pigment epithelium, and you see just a few spots here where the ISOS should have been lying. And then there's another layer between the ISOS and the retinal pigment epithelium that's in adults called COST, or cone outer segment terminals, but in children it's called the OSRP layer. So that's missing as well. Now all of us see this. Sometimes they come aphakic to us, surgical aphakia, because someone's done a cataract surgery. Rubella common, and it's very easy to diagnose. And we know this is the classical textbook picture of salt and pepper retinopathy. So we described a case, and now we have a series which is not yet published on what rubella OCT looks like. So what we found is this very jagged appearance of the outer plexiform layer. It's very easy in spectral domain OCT that the white layers are plexiform and the black layers are nuclear. If you just remember that much, so this is the inner, the outer nuclear, and that's the inner nuclear, and the whites are plexiform. So this white layer is a jagged plexiform layer, and you see a very attenuated foveal tent. It's not going up there, and a fairly involved retinal pigment epithelium, which we know happens because that's why you get the salt and pepper retinopathy. So it's not just that the RPE is involved. There are even layers in the inner retina and the mid retina that get involved in rubella. Fortunately, we don't see this, or perhaps it's not reported in our country. This case has been borrowed from Bascom Palmer. This is when you see these kind of marks, sometimes subretinal and preretinal, and if you see hemorrhage at different planes in a child, especially in our country, unfortunately in girl children, then please suspect shaken baby syndrome. In fact, this was one of the first published reports of the use of OCT in pediatric retinal conditions, and its use as medico-legal evidence in the United States. So when you see this, and typically as Dr. Naresh just described, you see exactly what's described in vitreomacular traction. So you have mounds of retina, you have something called a foveal separation. The fovea actually detaches to a point where it's lifted by multiple vitreoretinal interface problems. So, and this is used as medico-legal evidence, so remember this is a very important OCT to know even if we don't see it often. We also showed that even in spite of heavy laser and let's say aggressive posterior ROP, you can use OCT to pick up residual neovascularization. Now this media is hazy, it's just a few days after laser, and there's a persistent NV that has to be picked up, and that can be targeted in the OCT. Now just 4 cases of uvea. I have 3 minutes left. So again, this case is borrowed from Dr. Anita Agarwal. She's published in that textbook. And cat scratch disease, although this macular star appearance we can see even in, let's say, malignant hypertension. So it's important to know this and see what it looks like on an OCT. Of course, this is the retinal exudate. And so this is the slightly older version, but you see that there's lipid exudation and a subfoveal lift, and even lipid in the outer plexiform layer, these red dots there. Chikungunya retinitis, Dr. Padmamalini described that first. And basically it shows a whole lot of hazy media with patches of retina. It's important to know that along with reflective vitreous cells, you get fluid in the outer retina and hyperreflective patches along the areas of retinitis. This is again a condition that's probably more noted by, let's say, uvea specialists or retina people, but hypopigmented spots so commonly seen in general outpatient care, and they classically present with the hyperpigmentation. And then on OCT, they will show this focal reflectivity and ISOS disruption. Again and again, we talk about this disruption here and irregularity, and of course vitreous cells. And this is usually a prodromal condition that goes away on its own. And then now with the re-advent of HIV in our population, we're going to start seeing, if we haven't already, an increase in this progressive outer retinal necrosis PON, and this is a case of a 33-year-old HIV positive, even though he's on immunomodulating treatment, develops first a deep retinal patch. You can appreciate this is under the vessel, so it's much deeper retina, and that should have been picked up on the OCT, but what happens is the retina is so thickened because of the edema that you often don't pick up the outer retinal layers because of the back shadowing. And when it spreads within a matter of days, you can see this is just 3 weeks despite being treated. And then what unfortunately happens is the entire retina gets totally eaten up, and these patients often go up into having, let's say, retinal detachment and so on. So if you see it at an end stage, the OCT looks completely different from if you had seen it in the acute stage. So the summary really is, my co-speakers are going to tell you how it's used in cornea, glaucoma, inner and outer retina, and so on. But remember, it's also very, very useful, increasing conditions now, to use it in pediatric retinal conditions and uveitic conditions. It helps you come up with the level, which layer is affected. It also helps you decide the treatment chronology, what you've done now and what's happening later. Response to treatment, especially when you're looking at, let's say, inflammatory membranes and so on, or in the condition that I showed you, retinopathy of prematurity. And you can also map complications. And then one more we found was the medico-legal importance of this. A lot of these cases are taken from the Spectral Domain OCT book, which we published with Elsevier. Thank you very much for the opportunity.
Very good. Thanks a lot, Dr. Venegar. Anybody want? I mean, he has shown us such a versatile thing happening, like doing an OCT in a child and all. And a lot of people are...
diagnostic modality tool in glaucoma, optical coherence tomography. Ever since its advent more than a decade ago, it has gradually gained importance in glaucoma and is becoming almost commonplace to assess all glaucoma patients with the OCT. it is able to give us an objective quantitative data of all structures affected by glaucoma. The optic nerve head, the retinal nerve fiber layer, and the ganglion cell complex. It has also grown leaps and bounds in terms of technology. And now with the spectral domain OCT, we are able to in fact take video rate image acquisition, so that the inherent advantage being that more data is collected in a very short period of time with an excellent resolution and reproducibility. Also, because scan registration is now possible, we have less inter-test variability. So although the two technologies seem to have equal predictive power in picking up glaucoma, the spectral domain has the advantage of better linear progression detection. Quantitative imaging in glaucoma has been important because one, the visual fields are subjective and have low repeatability, and because structural loss precedes the functional loss as is shown by various studies. Also, the structural loss is of such a greater magnitude that the potential to pick it up is obviously better. As is true of any new technology, there is an onus on the physician to understand the inherent pearls and pitfalls or shortcomings of the technology, and not to unnecessarily start treatment just on the basis of abnormal OCT reports. So all in all, we do hope that it makes us better clairvoyant in terms of detecting glaucoma progression, but remember that a glaucoma specialist's eye examination continues to hold a very important position. The RNFL measurement is taken in a 3.4 millimeter radius circle centered around the optic disc and is given both in terms of sectoral as well as in a TSNIT profile pattern. This is matched to normative databases and color-coded green, yellow or red depending upon the probability of it falling within age-matched normals. Look out for the isn't rule and be sure that the optic disc size and axial length is within normal limits, because that can affect the reliability and affects the thickness, because larger discs will have a falsely high RNFL and longer eyes are going to have a falsely low RNFL capture. The inferior RNFL average is considered to be the best factor to discriminate healthy from glaucomatous eyes. The optic nerve head markings are done based on anatomical landmarks. The optic cup and the optic disc is in the spectral domain OCT already marked, and it's also corrected by the Cirrus HD OCT for anatomical abnormalities like optic disc tilt and peripapillary atrophy, as all data is in the same plane as the optic disc. This is what a normal optic nerve head report looks like in the RT view, with the typical RNFL thickness coming up as an hourglass pattern. The RNFL shown in quadrants as well as plotted in the TSNIT, and the parameters shown here. No glaucoma specialist really goes by the numerical values, more by the profile. Of particular interest in detecting glaucoma in the pre-perimetric stage as well as in detecting early progression is the ganglion cell complex study, and spectral domain OCT allows us to actually measure the layers. The RT view measures the inner three layers, while the Cirrus measures two of the layers, excludes the internal limiting membrane when taking into consideration the ganglion cell complex. So the technologies cannot be taken, like has been said, they cannot be compared to each other. This is what a typical GCC report would look like. The thickness map color-coded for brighter shades for thicker areas and in cooler shades for thinner areas. The deviation map shows any deviation outside the expected variability, and the significance map then is derived from the deviation map based on the statistical significance of this deviation. The parameters studied here are the global loss volume and the focal loss volume, measuring the average amount and the average focal loss volume over the GCC map. The FLV is said to be the most accurate parameter to differentiate normal from glaucoma eyes. Also be careful that you may have a patient where the RNFL is normal but the GCC is abnormal, and this is correlating both clinically as well as with the field report. This happens because the RNFL loss may not fall within the 3.4 millimeter circle where we are measuring the RNFL. So taking an overall picture of the significance map, the thickness map and the RNFL along with the parameters has a better diagnostic sensitivity of almost 86% than if any of the measures are used by themselves. And the GCC has a better marker of disease progression. Progression is analyzed both as an event, that is any change beyond the expected variability, and as a trend that looks at the rate of change over time. So rate of change is especially important because you have to diagnose rapid glaucoma changes of fast progressor patients where the treatment will have to be more aggressive. Progression is analyzed in terms of image progression, TSNIT profile progression, and the average RNFL loss. And for this you need two baseline examinations. The subsequent examination is then compared to these two. Any change outside expected variability is color-coded as yellow, and if it is sustained subsequent visits, it's flagged as red. This is same as for the RNFL thickness profile. And in the end, a summary map is there to indicate color-coded fashion the likelihood of progression using the various parameters. The RTView shows RNFL change analysis as well as a change analysis along the GCC map. It has been studied that based on the OCT RLFL, what is the expected field that one can get, and the Zeiss Cirrus has lately come up with a combined report where the expected field report based on the OCT can be compared with the actual field report to give good structure function correlation. Now coming up with certain tips to enhance the utility of OCT as well as to study it well, choose the right scan for the right pathology. Make sure that the patient's head position is normal, there's no head tilt, and the scans are centered well. In time domain, the operator has to center the scan, but in spectral domain OCT, there is an auto-centration. The average RNFL can be very widely affected, or the distribution of the profile can be affected if the scan position is shifted either horizontally or vertically. So in this patient, if the scan position is coming downwards, you are going to have a shift in the profile, which can be seen. So this is something that has to be looked out for in all scans that we interpret. Even an 8-degree tilt in this patient is showing that the shift in RNFL is moving down, and there is accordingly a shift in the profile also. The signal strength for the RTView should be more than 45, and for the Cirrus should be more than 7. Anything less than this should not be taken very seriously. And the signal strength, poor signal strength seems to affect the superior and nasal quadrants most. Make sure that the ocular surface is well lubricated, and if required, the pupil is dilated. Always look at the profile and the sector analysis more than just the numbers, and use overall inferior or superior quadrants as below normal are more reliable. Look at the inferior temporal region, which is where the structural loss initially comes up with, and compare the two eyes. If you have a loss only in the nasal fibers, be very careful or cautious to interpret that report. Self-explanatory but nonetheless important, check correlation with the visual fields as is seen in this patient. And also be careful that there are times when you will have a perimetric glaucoma and a normal OCT study. This can happen because of extensively diffuse component or a reduction that does not fall outside the normal limits. So be careful. And some people make progress just by structural or functional tests alone. Be aware that you are comparing to a very restricted normative database, and remember that the technique has limitations like blink or ocular movements or confounding ocular disease like peripapillary atrophy, high myopia, and macular pathologies. However, even in these situations, the normative, the study that you have taken can be seen for linear progression.